Dear Chairman, thank you for the invitation to present at the EBC meeting 2021. The title of my presentation is Diagnostic Accuracy of Quantitative Flow Ratio from a Single Angiographic View, Methods based on Bifurcation Fractal Law. Come from Shanghai Jiaotong University. This is my disclosure. Several studies have presented there was a mismatch between anatomy and physiology in bifurcation lesion, especially in gel fibrils. We developed a dedicated bifurcation model for quantification of the bifurcation lesion, especially at the bifurcation core here. So instead of using a straight diameter, we are using half the diameter from the main vessel and half the diameter from the side branch, combine them together to assess the diameter and also the stenting stability at the bifurcation core. The right figure shows an example of the analysis of true bifurcation lesion. Nevertheless, even using this dedicated 3D bifurcation model, the discordance between anatomy and physiology could not be reduced, indicating that we need more than QCA. So we developed also the angiographic-based QFR and to calculate FFR from angiographic image. The QFR has been integrated into the Angio Plus system by Postmedical and the QAngio XS 3D by Medis. Both systems have the same algorithm. It has been extensively validated in a number of studies across different countries, published in this journal, showing that there was high diagnostic concordance between QFR and FFR. Nevertheless, there was still a limitation of the first generation of QFR. First, you need two projections, and especially in the second angiographic view, there might be vessel overlap. This could reduce the analysis feasibility. Second, manual frame counting might increase the analysis time and reproducibility. Third, lumen contouring might need manual correction and introduce variability as well. So the linear tapering reference vessel might decrease the accuracy in analysis of the bifurcation lesion. So this figure shows an example. Using the linear tapering reference vessel, we will overestimate the stenosis stability distal to the bifurcation core. And now in this new generation, the second generation QFR, this problem has been resolved. So we are using the true reference diameter with a step down diameter across the bifurcation. So this would have a better presentation of the true bifurcation anatomy. In addition, we are using artificial intelligence to improve the automation in the QFR analysis. So this new generation is called MU-QFR or Mu-Ray Bifurcation Fractal Law based QFR. It can calculate the QFR from a single angiographic view. This would improve the feasibility and include all the side branch into the analysis that would further improve the accuracy. So using AI to improve the automation, this will improve the efficiency. So the average analysis time has been reduced roughly from 5 minutes to 1 minute. The solution has been available now in the Angio Plus core system by Postmedical Imaging. We validate MU-QFR in the Favor 2 China study population. So in total, MU-QFR and QCA analysis was performed in the optimal angiographic view and also in the suboptimal view in 330 vessels from 306 patients. The selection of the optimal angiographic view was performed before MU-QFR analysis. The inter- and intra-observability was performed in 50 vessels randomly selected from the population. The previous study have already showed the characteristic of the vessel in this study population. So bifurcation lesion was presented at 24.7% of the vessel, and tendon lesion in roughly half the patient, indicating this is the typical clinical population. So this is the main result. The MU-QFR had excellent correlation agreement with FFR. MU-QFR could be obtained in all cases with an average analysis time of 67 seconds. So using the optimal angiography with a minimal overlap and foreshortening, the MU-QFR has a high diagnostic accuracy of 93%, a sensitivity of 97.5%, and specificity of 96.2%. And both are significant, all are significantly better than the diameter stenosis. Indeed, using the suboptimal angiographic view with more foreshortening, that would slightly reduce the diagnostic accuracy from to 88.2%. However, still substantially better than the diameter stenosis, as shown in the ROC analysis here as well. Due to the use of the artificial intelligence to improve the automation, the interoperability and interoperability were low in MU-QFR analysis. In the end, I'm going to show two examples using MU-QFR for assessment of bifurcation lesion. The left figure shows the MU-QFR analysis before PCI. As you can see that due to the stenosis in the LAD, and also the bifurcation lesion here, the MU-QFR was 0.46 in the LAD and 0.52 in the diagonal. After PCI, the Nucleophile improved from 0.46 to 0.87 in the LAD and diagonal from 0.52 to 0.86 in the diagonal. In this case, we also measure the wear-based FFR. As you can see, the wear-based FFR were very close to the Nucleophile after PCI. This is another example showing that the analysis of Nucleophile in left main bifurcation lesion is more challenging. Before PCI, the Nucleophile was 0.68 for the circumflex and 0.50 for the LAD. After provisional stenting and the LAD in the left main and proximal LAD, the Nucleophile in the LAD improved to 0.89 and the Nucleophile in the circumflex improved to 0.88. There was still some stenosis and obtuse circumflex here, gel fibrance. In this case, we also measure the wear-based FFR in the circumflex. The wear-based FFR was 0.86, showing good concordance. So, ladies and gentlemen, in conclusion, computation of Nucleophile from a single angiographic view has high feasibility and excellent diagnostic accuracy in identifying hemodynamically significant coronary stenosis. The short analysis time and good reproducibility of Nucleophile has the potential of wider adoption of physiological assessment in the catheterization laboratory. Nucleophile can be a useful alternative for simultaneously anatomical and physiological evaluation of both the main vessel and the side branch. And thank you very much for your attention.